Kluger. I'm a professor of medicine in medical oncology. I see patients with kidney and skin cancers. I want to thank you all for joining us tonight. We have a wonderful panel of speakers who are going to talk to us specifically about kidney cancer. We will have 4 presentations total, and after that there'll be some time for questions and answers. If you have any questions, feel free to put them in the chat, and we will try to answer them at the end of each session to the best of our ability. So we have 4 of the 4 speakers. I'm going to start by introducing the first speaker. It's Dr. Patrick Kenney. He is one of our urologic surgeons, and he's going to talk to us about surgical approaches to kidney cancer. So Pat, take it away.
Thank you so much, Harriet. It's a pleasure to be here with everybody. As Dr. Kluger mentioned, I think we'll be taking some questions at the end. And as a surgeon, I have the pleasure of helping take care of patients throughout a variety of different parts of their cancer journey, but also throughout a variety of different kind of kidney cancer problems. So I think it would be really helpful to kind of first talk about some patient resources, but then also to review a little bit just about kind of kidney cancer 101. And we'll talk about what we call localized kidney cancer. So that's kidney cancer that's in the kidney itself, as well as the role for surgery in kind of more advanced or higher risk cancers. Some patient resources I think are excellent. There's a group called the Kidney Cancer Association. If you're not familiar, it's a really fantastic organization. The URL is www.kidneycancer.org. They have fantastic patient resources, very good pamphlets, information, blogs. There's some great videos, as well as the ability to really kind of get in touch and be part of the kidney cancer community. The Urology Care Foundation also has some excellent resources at urologyhealth.org. In particular, this kidney cancer patient guide, I think, is a very good and brief review. So I do have some kind of, this is a picture of a biopsy specimen of a benign tumor of the kidney. And I think one of the most important things for patients to know is that if you're diagnosed, or if a patient is diagnosed with a mass of the kidney or a tumor of the kidney, it's not necessarily cancer. About 7% of kidney tumors are something called an oncocytoma, which is a benign tumor of the kidney. Although it's difficult to distinguish on biopsy from some kidney cancers, they're quite common, and I see them a lot in my practice. They're very often treated because on imaging, they can look very much like a kidney cancer. At the bottom of the screen here is something called an angiomyolipoma, and this is a fat-containing tumor of the kidney. I highlighted it in yellow because it could be a little bit difficult to see because it's near the fat that's normally around the kidney. The vast majority of these are benign. They don't spread elsewhere, but they can bleed. So we often do treat them for that reason. But important to keep in mind that kidney tumor does not necessarily mean kidney cancer. Now, the majority of the kidney tumors we see are cancer. About 90% of the malignant or cancerous tumors of the kidney are something called renal cell carcinoma. That's a family, really a family of kidney cancers that are all separate, distinct tumors that arise from different kind of different parts of what's called the nephron, the functional unit of the kidney. About 5% of malignant kidney tumors are what's called urothelial cancer. That's the same type of cancer that impacts the bladder. It really arises from the lining of the urinary tract, which you can see here, which is this tan kind of urine collecting system. And only about 1% of malignant or cancerous tumors of the kidney are tumors that have spread to the kidney from another location. We can see it from a cancer called melanoma or breast cancers, lung cancers. And the most common other cancer that spreads to the kidney is lymphoma. But the focus of what we're speaking about tonight really is renal cell carcinoma, that family of related tumors that arise from what's called the nephron. This represents about 4% of new cancers in the United States. Last year, about 76,000 patients across the United States were diagnosed with kidney cancer. and about 14,000 patients died of kidney cancer last year in the United States. Over their lifetimes, up to 2% of the population will develop a kidney cancer. It predominantly happens as people age, so in the 6th, 7th, and 8th decades of life. But we do see it in younger patients. And you'll hear about that this evening, that there are hereditary syndromes that can impact the risk of kidney cancer. Risk factors is a very common question. I think the most important thing to know is that if someone developed a kidney cancer, it is very rarely due to something that they did. It's more common by chance. But there is an association with things like high blood pressure, smoking, being overweight. Chronic kidney disease or dialysis can increase the risk of developing a kidney cancer, as well as some exposures to chemicals like chlorinated solvents. You'll also hear about the idea of hereditary risk, and is there a gene or set of genes that may have impacted the risk of developing a kidney cancer? Again, kidney cancer, renal cell carcinoma really is a family of kidney tumors. The most common is something called clear cell kidney cancer. That represents about 3/4 of cases of kidney cancer. Papillary kidney cancer, of which there are 2 types, represents about 15 to 20% of kidney cancers, and chromophobe kidney cancer represents about 7%. The remainder are much less common, things like medullary, collecting duct, and translocation kidney cancers. The reason this is important is, although these are all renal cell carcinoma, they really have a very wide spectrum of behaviors. So this is really important for deciding about what type of treatment, how aggressive a treatment might be needed, or the risk of a cancer spreading elsewhere. It also can impact the types of treatments we offer and how people's tumors respond to that treatment. We often are asked questions about what's the stage of my tumor, and what tumor stage is rather simple. It's where are the cancer cells? And as a surgeon, I often see patients with stage 1 or 2 kidney cancers, and those are tumors that are confined to the kidney. They're stage 1 if it's 7 centimeters or less, stage 2 if they're greater than 7 centimeters. A stage 3 kidney cancer is shown here on the left. I think you can see my cursor. And it's a tumor that might involve the fat around the kidney, not just push against the fat, but actually microscopically grow into the fat around the kidney. Or it might involve the urine collecting system, or even the blood vessels that drain the kidney, called a tumor thrombus. Or it may be a tumor that's otherwise confined to the kidney, but which has spread to lymph nodes, these little green areas here, with some of which have yellow cancer within them. A stage 4 kidney cancer, on the other hand, may be in the kidney, but growing directly into an organ nearby, not spreading to it through the bloodstream necessarily, but growing into it, such as into the adrenal gland. Or a tumor that's confined to the kidney, but which has spread through the bloodstream to other places, either places like the lung, liver, bones, or also through the lymph nodes outside of the area near the kidney, such as the lymph nodes above the diaphragm. It's important to know that at the time of diagnosis, the vast majority of patients have a tumor that's confined to the kidney, about 70% of patients. About 14% of patients in the United States have tumors that are regional. So they either are growing outside of the kidney or into adjacent lymph nodes. The classic way that patients used to come in to see us, but this only happens about 5% or less of the time now, is with symptoms. So a mass that they could feel on their side, blood in the urine, or pain. This cancer type used to be called the internist tumor, because when it is larger or has spread elsewhere, it's very common for patients to have other symptoms, and they might be difficult to diagnose: weight loss, loss of energy, fevers even. And then blood changes in the values on their blood tests, like anemia or even high red blood cell count, high calcium, changes in their liver function tests. In the modern era, though, most patients don't have any symptoms, and these are discovered incidentally. This idea of incidental diagnosis, I think, is a really important one. It brings up this idea of what's called overdiagnosis. This is a chart that shows that over the past few decades, more and more people in the United States are being exposed to CT scans. And so we have more and more opportunity to find incidental tumors that might otherwise not cause patients a problem. And So the concept of overdiagnosis is when the diagnosis of a tumor is increasing, and throughout the 90s and early 2000s, it seemed like there was an epidemic of new kidney cancer being diagnosed. But at the same time, the number of patients who were dying from kidney cancer did not change. And so what this means is that we were diagnosing tumors that were not going to be harming patients. And so this is overdiagnosis. This is a really interesting study. The map of the United States here shows variation from different regions in the use of CAT scans. And so over a 5-year period of time, more than 40% of patients across the United States who have Medicare had a CAT scan of their chest or a CAT scan of their abdomen. And this varied by regions, as low as 30% in one area of California, higher than 50% in Sun City, Arizona. And really interestingly, the more frequently CAT scans were happening in an area, the more frequently patients were having nephrectomy, meaning their kidneys removed. And so if a patient lives in a high scanning region, they're actually at higher risk of losing a kidney and the risks associated with that. So this brings up something really important. How do we decide how to treat a patient who has a kidney tumor? And what I would argue is that for small kidney masses, one of the first things we should think about is something called active surveillance. And this is the idea where we need to uncouple the idea of diagnosing that tumor, the one that's incidental on a CAT scan, from the treatment of that kidney tumor. We know that 20 to 30% of those small masses are benign, like those tumors I mentioned at the beginning. And if they're cancer, they're commonly what's called indolent, not aggressive. This is an ideal approach for masses that are less than 3 centimeters in size, or even up to 4 centimeters, that are low stage. And what we do is we image every 6 months, and we look to see if it's growing faster than we'd like, so more than 5 millimeters a year, or if it's grown to be above 3 centimeters, and in some patients 4 centimeters. And at that point, that's when we would intervene and do a procedure to treat the tumor. So what are the outcomes? Well, with this, with 10 years of follow-up in a large series of patients, there was no difference in what's called cancer-specific survival, meaning being alive and not having died of kidney cancer. And so 99% in either group, whether you had treatment up front or whether you went on surveillance, there was greater than 99% cancer-specific survival at 10 years. And importantly, 2/3 of patients didn't meet a trigger for coming off of surveillance. So it either didn't grow or grew slowly. And also really importantly, half of the patients in this group who came off surveillance because they chose to, and so had treatment for their preference. Really important to know that active surveillance is an option. It's a safe option. And the risk of spread in published active surveillance series ranges from up to 2%. But it's really important to know that's only been in masses greater than 3 centimeters that are growing. So it's a very, very safe option for masses less than 3 centimeters, particularly if they're growing at a slow rate or not at all. Maslow said something in the 1960s, I suppose it's tempting if the only tool you have is a hammer to treat everything as if it's a nail. And so as a surgeon, it can be really tempting to treat every patient with a small renal mass with surgery, and it's just not the right thing. Sometimes doing nothing can be very difficult. For patients, it can also be very difficult to not intervene on something. But this is a very innovative approach. That's an important one for all of us to recognize, that sometimes doing nothing is the right approach. Kidney mass biopsy. This is a question that comes up a lot. It used to not really be done unless we suspected lymphoma, cancer having spread to the kidney or infection. But because kidney mass biopsy in the modern era is so much better, with a low rate of complications, very little risk or no risk really of tumor seeding, and high accuracy, kidney mass biopsy can be really helpful. So it has what's called a positive predictive value of greater than 99%, meaning that if it diagnoses a kidney cancer, we can trust that diagnosis. The non-diagnostic rate is about 10% up to 14%. But if we do a repeat biopsy, that increases the rate of diagnosis substantially. Really importantly is there are limitations of biopsy. The kidney tumors can be heterogeneous, so not all areas of kidney tumors are the same. And biopsy isn't perfect for grade if it's an aggressive cancer or not. So there we shouldn't always do a kidney mass biopsy, but there are really important times where it's a great tool. This is what it looks like, where a patient has a CAT scan. This white line is a needle that's entering the kidney mass. This shows a needle entering the mass and taking out a small sample of tissue. So the idea of when to obtain a biopsy, it's sometimes, it really is sometimes. As one of my colleagues said, more than never, but less than always. And so we do it if we suspect lymphoma, abscess, or spread to the kidney, spread of another cancer to the kidney. If the patient's a candidate for active surveillance, depending on a biopsy result, we might do a biopsy. If we're planning on doing an ablation and not removing the tumor, that's a time to do a biopsy so we can define what it is. If the patient and the treatment team are willing to observe a tumor, depending on the biopsy result, a biopsy can be really, really helpful. It's not just biopsy, though, that can help us decide whether a mass is safe for surveillance. There is an imaging study called a sestamibi scan, and this is used typically for something else other than kidney tumors. But over the past 5 years or so, it's gotten increasing use. You can see at the top, this is what's called an oncocytoma, a benign tumor. And on a sestamibi, the oncocytoma lights up bright. This is a kidney tumor down here at the bottom, a kidney cancer down at the bottom. You can see it's what we call cold. It does not take up the sestamibi. Basically, the kidney cancers have a little pump in them that pumps the sestamibi out. And the oncocytomas are packed with something called mitochondria that take up the sestamibi, and they don't have the pumps to get rid of it. So that's why it's so hot. It's a very active area of investigation. We are using this here to help our patients decide on treatment for small kidney masses. It seems to be a good adjunct to biopsy, but it is still an area of investigation. So how do we treat localized kidney cancer? I ask my patients to think about 3 areas, to consider 3 things: cancer control, if that's important, if that's necessary, sparing kidney function, and then risks, recovery, and quality of life. So what is the evolution of kidney cancer surgery? What does it look like? From the 50s, 60s, 70s, and 80s, we really did radical nephrectomy. And so this is removal of the whole kidney, including lymph nodes, including the adrenal gland, all of the fat around the kidney. Radical meaning from the word meaning roots, right? To take the cancer up by its roots. And we only did what's called partial nephrectomy, just removing the mass and a thin rim of normal tissue, only in very select cases, such as if the patient only had 1 kidney. Starting in the 90s and the 2000s, we realized that we were able to not take out the adrenal gland because imaging had improved so much. If the adrenal looks normal, we don't take it out. Same thing for lymph nodes. We don't take them out unless they're abnormal. And then we started to do what's called elective partial nephrectomy. So doing a partial nephrectomy in patients who have 2 kidneys. From 2010 kind of beyond, we've done increasingly complex, minimally invasive surgery, including use of the surgical robot. A big advance has been in something called ERAS, enhanced recovery after surgery, where we're getting patients home and back to their usual lives faster. A lot of focus on preventing the complications of surgery, such as blood clot and surgical site infections. I think most importantly, integrating surgery with medications to treat the cancer. Why is this important? Well, surgical advances really are focused on risks, recovery, quality of life, sparing kidney function. And by doing that, we've really done less. So doing surveillance, doing partial nephrectomy, doing ablation, doing minimally invasive surgery. But surgical advances have not really done much from a cancer control perspective. What's done that really is doing more, meaning not just surgery, but integrating surgery with other treatment modalities such as medication. I'd like to quickly go through some of the treatment options. One is ablation. This is freezing or frying the mass. Most commonly here, we do what's called percutaneous or through the skin cryoablation. It's done by the interventional radiologist. It's a great option for masses less than 3 centimeters in size. It's a very low risk procedure, very well tolerated. People go home the same day, no incision. It spares kidney function similar to partial nephrectomy. That's great. It does have a slightly higher risk of cancer recurrence than surgery does. But the good news is a second ablation takes care of the vast majority of those. So it's a very, very good option if patients are not great surgical candidates, or in a very small, very accessible tumor in a patient who doesn't feel comfortable with surveillance. The key thing is location. This is an ideally situated tumor for ablation, far away from the blood vessels in the kidney. But if there can be tumors that are close to the blood vessels, close to the urine collecting system, where ablation is not a good option. This is just what ablation looks like. This is a tumor at the top of the left kidney. A biopsy was done, then an ultrasound, or then a cryotherapy probe was put in here. The patient did have a little bit of bleeding, you can see after the procedure, which is okay. They then had a small recurrence. They cut off the blood flow to that portion of the kidney. Then it was frozen. This is from a research paper, not from our center. It was frozen again. And then 4 years later, no sign of any cancer. It's a lot to go through, but the patient did not need surgery. Partial nephrectomy, like ablation, spares kidney, but it's surgery. And in that surgery, we remove the tumor, suture the rest of the kidney back together. This can be done open, laparoscopically, or much more commonly now, it's done robotically. We prioritize partial nephrectomy even when the tumors are highly, highly complex. If a patient has only one kidney, if there's tumors in both kidneys, or if they have chronic kidney disease. We know from retrospective research, looking back at the patients we've treated, that partial nephrectomy reduces the risk of chronic kidney disease compared to removing the whole thing, compared to radical nephrectomy, and it provides the exact same cancer control. This is a really, really important option for our patients and is very commonly employed. So partial nephrectomy these days is still done at many centers open. With an open incision, and that's okay. The key advantage of minimally invasive surgery, though, is a really significant improvement in patients' recovery. Even for highly complicated tumors like you see down here, we do the vast majority of our partial nephrectomies with robotic surgery here. I am a really big fan of the surgical robot. It's made by a company called Intuitive Surgical. It's pictured here. This is the console where the surgeon sits. It has a dual eyepiece that provides a 3D view. This is the robot itself that has 4 different minimally invasive instruments that we use to do the operation itself. And this is what's called the vision cart, where my assistant who's at the bedside is able to also see what's happening inside the abdomen. This is the eyepiece I look through. There's these are the hand pieces that control a whole variety of instruments, including a 3D camera and a variety of other instruments for suturing and for cauterizing and otherwise treating tissue. Radical nephrectomy, unlike partial nephrectomy, is we remove the entire kidney. We remove the fat around it. We remove, in some cases, the adrenal gland, and in some cases, lymph nodes. The factors that make us remove the entire kidney is if a partial nephrectomy is just not feasible. It's the radical nephrectomy is the standard approach for what's called a T1B tumor or higher. If the tumor is just highly complicated, if it's locally advanced, if it's involving the vein or lymph nodes, a standard approach is to remove the whole kidney. In general, there are fewer complications with radical nephrectomy than with partial nephrectomy, but obviously with losing the whole kidney, there is increased risk of developing chronic kidney disease. There is a time where we almost always do surgery these days still with open surgery, and that's if the kidney tumor invades a blood vessel. And so kidney tumors can invade a big vein in the belly called inferior vena cava, and that can even extend all the way up into the heart. In those cases, we have a team here of liver surgeons, heart surgeons, and urologists who treat those patients primarily with open surgery to remove the kidney and to remove the entire tumor thrombus. Kidney surgery for many patients, though, may not be enough. In some, obviously, it's not necessary. In others, it may not be enough. And so we've investigated what we call adjuvant therapy. And this is medications after surgery to reduce the risk of the cancer coming back. There have been dozens of trials done in kidney cancer dating back more than 50 years. All of them were negative until recently. There's a medication that has an FDA approval in the adjuvant setting. It's used by some medical oncologists. It's generally not used here, though. And this is a medication called sunitinib. It tends to cause a fair amount of complications. And what you can see here is this is what's called the overall survival curves. There's actually 2 lines there overlapping, and that drug does not seem to help patients live longer. We generally don't use it. There's a very promising study called Keynote 564, studying what's called an immune checkpoint drug, or it's a pembrolizumab or Pembro. And this showed a significant improvement in what's called disease-free survival, and some promising appearing curve for what's called overall survival, or helping patients live longer. It is FDA authorized, and we're still at this point, I think, very much as a whole field trying to sort out which patients are the appropriate patients for this drug. And we're all anxiously awaiting the overall survival data. I think the summary here is that not all kidney cancer is the same. It's important to know the type, the size, the stage, the location. It's important to decide on treatment if it's necessary, and if treatment is necessary, which is the best one. We should do less when we safely can, and use a team approach to the most challenging cases. And very clearly, integrating surgery and medication therapy is really a key frontier for us over the next decade. Thank you very much for your time.
Thank you so much, Dr. Kenney. That was great. I learned a lot. There are some questions in the chat that have been answered and some that haven't. So if okay with you, I'd just like to ask you those that have not been answered yet.
Please.
So there's a question about how often do you see a diagnosis of metastatic kidney cancer without a clear primary tumor?
That's a great question. We really don't, that happens a lot in other tumor types, but most often in kidney cancer, there's an obvious primary tumor. I myself have not taken care of a patient who's had metastatic kidney cancer without a primary. I'm not sure, Harriet or Michael or David, if you have.
Yeah,
I've seen it once.
Yeah, we have it. It happens a little, uncommonly. I think the question, maybe I'll answer this a little bit. There's sort of a few different possibilities. Every once in a long while, even though there's a tumor there, you can't exactly see it because it's about the same density on the scans as the other tissue. So there's really something there, but no one really detected it. And then the other thing that we know that happens sometimes in kidney cancer is that there's a tumor there that then sort of went away, even though other tumors have remained. And I think all of us who treat metastatic cancer have seen that. That happens in not that many cancers, but it does sometimes happen in kidney and melanoma, actually, which Dr. Kluger treats, that you'll see a tumor start and then go away. So maybe the tumor was there, then something spread, and then it went away.
Yeah, that's something called the abscopal effect or the Lazarus effect, where it happens. We see it in kidney cancer, especially if there's been a few reports of patients who have had a metastasis treated, either with ablation or radiation, and then the primary tumor or metastasis in other sites have melted away. It happens in kidney cancer, but quite rare.
Thank you. So there was a question about whether papillary renal cell carcinoma is the same as papillary thyroid. And actually, Dr. Braun, who's got the orange tie for kidney cancer, answered it. But I don't know that everybody saw that. And the answer is no, it's not. It just looks the same it has similar features under the microscope, but the cell of origin is quite different. Then, Patrick, there was a question about how often you have clear cell renal cell carcinoma that has both sarcomatoid and rhabdoid features.
So sarcomatoid and rhabdoid features themselves are relatively rare. In combination, we do see it, but also relatively rare. They are higher grade features of a kidney tumor. That tends to mean the tumor itself is more aggressive, and also may impact our treatment selection. For instance, if a patient has metastatic kidney cancer, sometimes surgery itself can be appropriate as a first treatment option. And if we know that a patient has a sarcomatoid kidney cancer or a rhabdoid kidney cancer that has spread elsewhere, oftentimes surgery may not be the right first approach for those patients, and where medication may be the first right approach. And in the case where the medication has done a good job of stabilizing the tumor, or the tumor has responded to the medication, surgery then might be an option. But sarcomatoid and rhabdoid together, relatively rare. I don't have a good sense of whether that would change a patient's prognosis. They're all still grade 4.
Then there's a question about, you made a comment about kidney disease, and I think sometimes as physicians we use terminology that's not all that clear. So there was a request for clarification about kidney disease versus kidney cancer.
Yeah, that's a great question. Thank you for pointing that out. I have to say I do tend to slip into medical words, and sorry. So kidney disease has to do with the ability of the kidneys to perform their job of filtration. So we have various different ways of measuring that. One of them is a blood test called serum creatinine. And when the creatinine is elevated, that indicates a reduction in kidney function. And we call that chronic kidney disease, or CKD. And that's when it's persistent over the course of weeks or months or longer. One of the key things about partial nephrectomy, active surveillance, ablation compared to radical nephrectomy is that for patients who have kidney disease or who are trying to prevent it, those what we call nephron sparing or kidney sparing approaches may be a better option because they're associated with a lower risk of developing kidney dysfunction.
Thank you for that. That was a great answer. Then there's a question about stage 3 cancer. There's a comment from somebody who had a 4.6 centimeter tumor, but it was called stage 3. Can you clarify that, how that's possible?
So, so a 4.6 centimeter tumor that can be stage 3 really kind of for two reasons. One would be if the tumor had associated in lymph nodes. So meaning if there was involvement of the lymph nodes, then no matter what the tumor size or T stage is, it would be a stage 3 tumor. Or if that tumor was involving the fat around the kidney or in the center of the kidney, the urine collecting system, or a blood vessel within the kidney. And that would be stage 3, even for very small tumors. And so I've taken care of patients who've had very, very, very small tumors that were stage 3, just based on involvement of those other features.
Okay. And then are there instances where somebody has metastatic kidney cancer and there's no surgery done?
Yeah, very, very, very commonly. So the paradigm starting about 20 years ago was to do something called cytoreductive nephrectomy. So to remove the kidney when in the setting of kidney cancer spread. And for a variety of reasons, we do that less commonly now. It's very, very nuanced. But there was an important study a few years ago called Carmina, and it was a study looking at use of a medication alone or a medication plus surgery. And it showed that medication alone performed just as well as surgery plus the medication. So very commonly these days, we take care of patients with kidney cancer that spread elsewhere, and they don't have to have surgery.
Thank you. Dr. Kenney, thank you so much for a wonderful presentation.
Sure.
And now I've got the distinct pleasure of introducing our second speaker. It's Dr. Michael Hurwitz, who is one of my fellow oncologists. Mike?
Yeah, so do I share screen here? Let's see if I can get this to work. Is it visible?
Yes, except we've got your slide sorter.
Well, hold on. Let me go to the beginning. Try that again. Wait a minute. Sorry, folks. Why isn't it going to? Now can everybody see it?
Yep.
Perfect. Okay. All right. Great. So, hi everyone. Welcome. Again, as Harriet said, I'm one of the medical oncologists, and I treat kidney cancers and also bladder and prostate cancers. And I'm going to talk about treatment of metastatic cancer. You know, I know that the topic here is supposed to be kidney cancer and all the various treatments that we give, but to some degree, I wanted to backtrack a little bit. And the reason for that is that not everybody knows some of these basics about cancer. And when I say not everybody, I mean, a lot of doctors who are not kidney or cancer doctors aren't exactly aware of a lot of the basics of cancer. And the reason that I want to talk about it this way is that I think to understand how we decide to treat metastatic cancer in the kidney, it makes sense to think about sort of what cancer really is. Okay, so let's start with what is cancer? Something really basic. And so cancer is made up of cells that don't behave normally. And what I mean by that is that cancer is really a disease of cells. It's a disease of individual cells that are doing what they should not be doing. And there are really three specific things that they do that are the hallmarks of cancers. So number one, they continue to divide even when they are not told to divide, okay? Two, they even continue to divide when they are told not to divide. So one is they continue to divide on their own. Another is when they're told to stop dividing, they continue to divide. And lastly, they won't die when they're supposed to. Now, some of this may not make sense to everyone here, but I think it's worth pointing out that all cells in the human body are really in continuous conversation with each other. Cells talk to each other in various ways. I'm going to go into that in a little bit. And they're always sending signals to each other to say things like, don't divide, do divide, make something, like make insulin, for example. And they're also told to die sometimes. A lot of cells are dying on purpose all the time. That is the way the society in your body works. So cancer is a disease where the cells have lost the ability to communicate and they're dividing when they shouldn't. You know, the vast majority of cells also that form cancers in adults form from the lining of tissues. Dr. Kenney actually referred to this before. And a lot of the linings, I don't know if everyone can see my cursor. Is that just me or can people see it? Pat, you're the only one who I don't know if you're able to.
Yeah, we can see it well.
Oh, good.
Yes.
Okay. All right. So normally we have these things called, it doesn't matter. They're the linings of tissues. And often these cells are neatly on them. And I show a cell with something called a nucleus in the middle of the cell. And then there's this process that happens when normal cells turn into cancers. And I also drew this grayish junk here, and that's called there's something called a submucosa, or there's this something called ground substance, and that's what these cells are sitting on. Okay, and that's a normal thing in most tissues. So the first thing that can happen is the cells can divide inappropriately, and then you get a lot of cells, but they don't look wrong, they're not doing anything all that abnormal. Then you have a precancerous stage. Sometimes we call these things adenoma, or in breast cancer we often call it DCIS or LCIS. And then this is when the cells start looking funny, but they haven't done anything definitively cancerous yet. We call it cancer when they have actually invaded into a tissue, okay? An invasion means breaking out of this underlying membrane. That is the way we define cancer. And again, the cause of it is what I said before. There we go. Okay, so I've said cancer is a disease where cells misbehave. And the question is, why aren't they behaving? And the basic answer is that there is something called DNA mutation. So DNA is the blueprint for everything that is done by a cell in the body. So everything that is done in your body is done based on a code, and that blueprint that encodes it is made up of DNA, which is a string of actually code. I've drawn it here. Everyone's got two of the same piece of code in their body. So we have paired, what are called chromosomes. I only drew two here. We actually have 23 pairs, but either way, when a cell starts, maybe there's a mutation in it. Okay, and I've drawn it as an X. All right. What distinguishes cancer from other diseases in the body is that cancer cannot control. Cancer cells are very bad at fixing DNA mutations. Normally, if you have a DNA mutation, either it will be fixed or the cell will say, I can't fix it. The cell will kill itself. That doesn't happen with cancer. And this leads to two things. First of all, what happens is more mutations develop as the cells divide, okay? The second thing that happens is in every cell division, you're gonna get different cells, right? Because mutations are developing all the time. But the same mutation that happens in this cell isn't necessarily going to happen in this cell. So every time there's division, you can get more and more mutations. Is this healthy? No. Many of the cells in cancers will die. Cancer cells are not particularly healthy, but some of them will develop what we call malignant clones, and they will go on to form these cancers that are very hard to control because the blueprint is wrong. They're no longer doing what they're supposed to be doing. And the last thing I want to talk about is sort of what is cancer. It's something called metastasis. I know we've all heard the term. Metastasis means when there is spread of a cancer from one area to another area. And it means it's not continuous, meaning it's not the whole tumor mass growing. It's actually a cell breaking off and going somewhere else in the body, okay? So first, it's worth pointing out, if everyone doesn't know this, and there's no reason you would know this, that many cells in the body are able to move. They can migrate. And that is what happens in cancer. So that's what's required for metastasis. Once they move somewhere, they have to find a place that can support their growth. Okay. And there's this idea of a seed and soil hypothesis. For example, kidney cancers often go to bones. They often go to lung. Sometimes they go to liver. Other cancers don't go to those places. And that's because, in addition to the fact that there's a blood supply that sends it to certain places, they can only go and land in certain places and grow there. Okay. And then lastly, once they do get there, they have to be able to set up a food supply, which really means a blood supply. And that we have a term for that, which is angiogenesis. And that's going to be really important for how we treat kidney cancers. Okay, moving on. I want to talk about how the cells actually talk to each other, because I mentioned that cells talk to each other all the time. And the way they talk to each other is they send things out of one cell and it goes to something on the other cell, and the other cell has what's called a receptor to bind it. It's sort of like a lock and key. So here's an example. I have the outside of the cell here, and here's the cell membrane, and here's a receptor or a lock, okay? And this thing is a key. It's something called EGF. It's sent from somewhere else. And when it binds to this thing turns or it changes. And actually, there are things called phosphorylated groups that end up on that. Once those things are there, something inside the cell will find it. They're moving around each other all the time, and it will bind to it because this thing recognizes it. So it'll bind to it, and it brings in a friend. And that friend brings in yet another thing that binds to it. And this thing called RAS is very important in cancer. These things that I'm talking about, they're not just little things that bind to each other. They're actually little molecular machines, okay? This machine just sticks things together, okay? It's an adapter. But this is a machine that turns this machine on, okay? And once this thing is on, it's a general on switch. Oops, that turns on another protein, which turns on another protein, which turns on another protein, and that results in cells dividing. That's actually a normal process. We want that a lot of the time. You often need cells to divide, okay? You need it every day, but you don't always want it. In cancer, it's happening when it shouldn't be happening. All right, so what's unique about kidney cancer? That's my general view of what cancer is. All right, so kidney cancer is actually, as Dr. Kenney pointed out, a whole big group of cancers. Now, the vast majority of it, about 90% of it or more, are the types that some of which were mentioned by Dr. Kenney. Clear cell carcinoma is the most common. That's about 75% of it. Then there's something called papillary and chromophobe, which was mentioned before. In addition to the fact that we know there are certain types of cancers, there's also something called kidney cancer syndromes, where they run in families. And the reason they have these cancers is because one of their genes has a DNA mutation that results in a predisposition for these things to occur. And the one I want to talk about is something called von Hippel-Lindau. So von Hippel-Lindau is a disease that results in tumors in many different organs, but probably the most famous one is in the kidneys. So what is von Hippel-Lindau? So von Hippel-Lindau is a protein that is important in something called oxygen sensing. So the cells in your body are able to actually sense when there's oxygen there. And when there isn't much oxygen there, they think, why isn't there oxygen there? Probably there's no blood supply. And what happens is they send out more signals to develop blood vessels. So when there's normal oxygen, this protein called VHL is on. What VHL does is it turns the oxygen sensing pathway off. All right. So oxygen present, VHL is on, nothing happens. If the pathway is off, nothing, the machines are all off. But when there's a low oxygen level, VHL is turned off. And then the oxygen sensing pathway is on, and that results, in blood vessel growth, in cell division, and in some cell movement. In kidney cancer, and people who have mutations in this VHL gene, VHL is always off because it's broken. So the oxygen sensing pathway is on all the time. And so that predisposes these cancers to develop. And why is that so important? Because it turns out that we have medications that actually block parts of that oxygen sensing pathway. And actually there's a new one that I didn't put on here called belzutifan. I don't know if Dr. Braun is going to talk about that. He's nodding. He is going to talk about that. So let's not forget about belzutifan. But these are all medications that work similarly to turn off the oxygen sensing pathway. The other medications that we use in kidney cancer are generally things that turn on the immune system in one way or the other. And this sounds like a distinction without a difference, but it is a difference. And that's how I'm going to end this, by talking about the difference. Oops. One are things that actually activate the immune system to turn on. And the other type are ones that prevent the immune system from being turned off. Notably, these things are all pills. Everything else is actually given by vein. And the last thing is, we do not use chemotherapy in kidney cancer. It does not work. There are various theories why it doesn't work, which we can talk about, but it just doesn't work, so we don't use it. But all the other drugs, aside from the ones that I mentioned that have to do with oxygen sensing and VHL, they have to do with the immune system. All right, let's talk a little bit about immunity. The immune system is something that all it does, its whole job is to distinguish the self from foreigners, and then mostly to get rid of foreigners. So the way you distinguish yourself is that every cell in our body is continuously taking bits of the cell from the inside, sticking them on the surface, and telling our immune system, this is part of the immune system called T cells, and saying, hey, this is me. I'm part of us. And T cells, generally, the ones that used to recognize this stuff, they've mostly gone away, because if a T cell recognizes something strongly, it tries to kill it, okay? And that's sort of how immunity works. So when you get a bacteria, let's say, that invades one of your cells, the cell doesn't just show bits of itself, it also shows bits of the bacteria. And the T cell may recognize that and say, oh, this is a problem. I better kill that cell because it harbors bad bacteria. Turns out that isn't enough. You need a second signal. And that second signal, don't worry about the name of it, but you need a second signal. Basically, cells that are invaded by bad things send out a second flag saying, not only do they show you the bacteria as part of it, but they say something's going very wrong. And that's recognized by the immune system, particularly T cells, and that turns them on. We call that co-stimulation. And this is hopefully the endpoint. Uh-oh. Oh, there we go. That's what we're looking for. It kills it. And that's the way the immune system works. Why am I talking about this? What does that have to do with cancer? Oh, sorry. Before I get to that, there are two other things. In addition to having that thing called co-stimulation that turns it on, we also have things that turn the immune system off, because you don't want the immune system on all the time. And one way is to block the flag. The T cell blocks that flag with this protein, and with it, the T cell doesn't recognize it anymore. And another way is that we have another set of something called PD-1 and PD-L1, and that also is a signal that says turn T cells on. Okay, getting back to cancer. So as I said, we distinguish ourselves from foreigners by taking bits of us, putting them on our surfaces, and it's not recognized by the immune system. But when you have cancer, the cancer cells are abnormal, and a lot of what's on their insides are abnormal, and they put that on the surface, and it's recognized as foreign by the T cell. So I said that those two other types of things that we use to kill cancer, that we use to treat them, are both immune modulators. And one way that we did it was to turn T cells on. The best example is something called interleukin-2. We still use it, but not that commonly anymore. It doesn't work that well, to be honest. We can talk about that more if people have questions. But basically, just activating the T cell on. And that works somewhat. But what we found that works much, much, much better, really, and more consistently, is to stop the signals that turn T cells off. And that's what most of the medications we use nowadays are. So, whoops, sorry, folks. Okay, so going back to our treatments, and then I'm gonna end. We can treat by blocking oxygen sensing, which turns off the cell division probably of those cells, the cancer cells, and also prevents a lot of blood vessel formation, which is important for kidney cancers. We can turn the immune system on, but again, these have a lot of toxicities. They don't work that well. They can only be done by specialists at very specialized centers. We do it here, but most places don't. And then there's this large group, this other group of sort of growing group of drugs that prevent the immune system from being turned off. And to be brief, we use these a lot, we use these a lot, and we use them in combinations, because in combinations, they work better than working alone. And that's what I was going to say today. Oh, sorry. The last thing I was going to talk about was, why don't therapies work? We've all had friends or even us, we have cancer, a therapy works and then it stops working. So one reason that things stop working is what I said before about cancers. Remember how I said that every time the cells divide, you can develop new mutations? And every cell that has different mutations is essentially is going to act differently. And so at some point, even though you're controlling a lot of the growth, you're going to get growth of things that are resistant because they're different. The other thing that's really important is that cancers have the ability over time, by mutating, to develop evasion from the immune system. Another reason why it's hard to treat cancers and why therapies don't work is that parts of the tumors aren't getting a blood supply very well, so they're not getting a lot of drug in to treat them. And tumors are actually under pressure, so it's really hard to get drug in. And that's a major reason why big tumors, especially that have a lot of what's called necrosis or cell death in them, aren't very well treated. And lastly, many of the tumors that we have, tumor cells that we have, a lot of the cells are very, very slow growing. It's very hard to kill things that are slow growing for various reasons that we can talk about. And with that, thanks for listening. I don't know if there are any questions, but I will stop sharing.
Oh.
Yeah, I don't know if I went way over or
No, that's a wonderful overview, I think, on the foundations of cancer, which is a really good thing to understand. And there's definitely comments in the chat about how that fundamental understanding, I think, is helpful for most people at a really good level as well, to understand the process that's going on, and then to talk about treatments. A couple questions have come up. So the first is about Opdivo therapy specifically, so an immunotherapy, and you hear a lot about it, and there's just a base question: does it actually cure cancer?
Yeah, so Opdivo is one of the ones I put there. So because we're sort of academic, we don't put the trade names. We only put the names of the drugs that are that are sort of the generic names. Nivolumab is Opdivo, and there are probably cures, especially with combinations of Opdivo and this other drug, ipilimumab. It's hard to say definitively, honestly, because kidney cancers can come back many, many, many years later. And we probably first started treating people with these drugs about 10, 12 years ago. Maybe a few patients were treated a little bit before that, but yeah, there are people who appear to be cured from that.
And so another one is sort of a clarification about terminology. It's someone who
saw that is so bad. Yeah. So the question was, we got cabozantinib. The paperwork we received indicated chemotherapy. Is that the question that you're asking? Yeah, absolutely. That was terrible on my part. I apologize. So, chemotherapy is a very poorly bandied about term. So chemotherapy originally was described in the 1960s. And it was because we have radiation therapy, we have surgical therapy, but what are we going to call therapy with medicines? We'll call it chemotherapy. And then in the 70s and 80s, chemotherapy became this thing that people think about as drugs given by vein that cause nausea and hair loss and act in a certain way. You are absolutely right. All of it's chemotherapy. What I was talking about, and I was not being clear, we don't use traditional chemotherapy or what we call cytotoxic chemotherapy that is a little bit less specific but kills abnormally growing cells.
So there's a couple more questions. One is about biomarkers, and I'll actually talk about that a little bit in the next session. There's a couple more questions. So one that come up that's sort of more general is sort of the importance about being treated as sort of a center of excellence, and an academic center that sort of sees a lot of kidney cancer. And maybe if you could speak a little bit about that, why that might be helpful in certain cases.
Yeah, so I think that the job of a general oncologist is almost impossible. There's so much to know. And not only do you have to know every single disease, but you don't have other people floating around you who do other things that are relevant. So one of the great, great joys of my existence is when something that I have no idea that comes up that may have to do with localized treatment or with taking something out, I can call Pat and he's right there just to answer it. And so one of the things that you get from going to a center of excellence is that there are a lot of us around. We all can communicate with each other. And we have, as a group, we have seen a huge amount of different things. The other thing is that because people like Dr. Braun and Dr. Kluger and I really only treat 1 or 2 diseases, or in my case, 4 diseases, whatever, you see a lot of the same thing, and you've probably seen a lot more of things. Maybe sometimes we're a little more up to date because we can follow only 4 things rather than 100 things. But I think the best thing about the center is just the multidisciplinary features. We have we have pathologists who know a ton about the stuff, who can really tell us what we're looking at under the microscope. And sometimes other people can't, frankly. We have fantastic radiologists who are used to dealing with a lot of cancer. And we have interventional radiologists who can do amazing things, and radiation oncologists who know how to deal with kidney cancer. And many don't, because it's not thought to be a radiation treated disease, even though in many ways it is. That would be my answer. I'm sure everyone else has his own or her own answer.
I couldn't agree with you more, Michael. I mean, I think there's other specialties too that don't immediately come to mind. We have a nephrology team here, including someone who specializes in onconephrology. So nephrology is medical doctors for the kidney, for chronic kidney disease that we had talked about earlier. And there's someone who specializes in that in patients with cancer. That's an extraordinary resource. From a surgical standpoint, I had put up a slide very briefly about tumor thrombus, or other, that's when the tumor can extend even up into the heart. As a general hospital, right, we have liver transplant programs and liver transplant surgeons. We have cardiac surgeons who are extraordinarily experienced, and we can call on those resources when we need to. And that's something that I think is really pretty incredible. So the advantage, even just having trainees around, there's a lot of data that having trainees around helps improve outcomes. There's something really kind of magic in the water, and hopefully that translates into better outcomes and hopefully better care.
No, and you think of even this call, we have urology, surgery, we have medical oncology, we have genetics, we have even this one call, sort of a few different specialties represented. And so I think that's something unique about places like Yale and then these centers of excellence that really enable that. So maybe in the interest of time, we might move forward a little bit. I think there's still a couple of questions, but I think we'll hopefully have time at the end to loop back to those.
Yeah, David, you can answer some of those when you're done, maybe, if there aren't more questions for you specifically, because I see what they are. So you're up.
Okay, can you see my screen okay?
Yep.
Okay, great. So I'm tasked with a relatively large topic, which is to talk about research in kidney cancer. And really the focus of what I'm going to talk about is basic and translational research. That's often research that's done in a laboratory bench, and that's brought back to patients to try to think about how we can better understand the disease, and most importantly, how we can better treat it. There's a lot to cover, so I'm going to warn you in advance. I'm going to editorialize a fair bit of what I think are sort of some of the big open questions in kidney cancer, and just a little taste of how we are beginning to address it. And there's a huge amount of research going on, a lot that I won't be able to cover here, but hopefully my real hope for this sort of talk is to give you kind of a sense of the excitement in the field about how much things are changing, how many things are being studied, and how I think the future is very bright for this disease. So I think before we get started, it's helpful to take a step back. I always think to sort of know where you're going, you have to sort of know where you came from. And so to take a step back, not that long ago, 20 years ago, to look at what kidney cancer treatment was like then. Try to restart this. Sorry about that. Are you able to see the screen okay now?
Yeah.
Perfect. I apologize. My computer decided a bad time to freeze, so I'm going to try one more time to restart this. My apologies. How about now?
Perfect. It's moving.
Perfect. Okay. Third time's the charm. Thank you, everyone, for sticking with me. So I was saying, I think it's really helpful to look historically about what kidney cancer treatment was like, just 20 years ago. And so if we look at the historical data, and this is largely patients treated with, as Dr. Hurwitz was saying, things like interferon and high dose IL-2. And again, we show a survival curve. This is something that Dr. Kenney showed, which is shown over time the number of patients that are surviving at 1 year, 12 months, 2 years, 3 years, 4 years, or 5 years. And unfortunately, 20 years ago, we saw this curve drop down quickly. And so that if we go to that 5-year mark, that 60-month mark, we see it was in the single digits in terms of the number of patients who are actually surviving that long with advanced kidney cancers, probably around 5 to 10%. Now, if we contrast that with some of the modern therapies we have, the ones that Dr. Hurwitz mentioned, like ipilimumab and nivolumab, these immunotherapies, we're starting to have longer follow-up. So 5-year follow-up of those two drugs together, sometimes we call them Nivo and Ipi, and we see a dramatic improvement. Now, 48%, nearly half of people with advanced kidney cancer are alive 5 years later. This is an incredible improvement, but also I think shows the road that we still need to take, in the sort of mountain we need to overcome. 48% is incredibly different from 5 or 7%, but it's not 50%, it's not 70%, it's not 90%. And so we still have a huge way to go. And that's where really fundamental research into the disease comes into play. And so out of all of the potential areas of research, there's a couple that I really want to focus on. And these are some of what I think of as the sort of critical questions, the big open questions in kidney cancer. One of them was actually brought up in the chat, which is a great segue. One is, how do we select the right drug for the right patients? We know one drug might not work for everyone. This drug A might work for a group of people. Drug B might work for a different group of people. So how do we select that right drug for the right patient? Another word for that is biomarker, a test we can do to try to select the right therapy. The second is, how do we increase that number of patients with long-term survival? I showed what I call the tail of the curve that was sort of flattening out over time, where nearly half of patients, 48% of patients, were alive 5 years later, but 48% is not 70%. So how can we continue to increase that number? And I would argue that understanding, as Dr. Hurwitz was talking about, how the immune biology of kidney cancer works and understanding other elements of its biology to develop new therapies is going to be critical. As Dr. Hurwitz mentioned, getting anti-PD-1 therapy or immune-based therapy is now really a standard in kidney cancer. Most patients with advanced clear cell kidney cancer would receive this, but unfortunately, many patients ultimately progress. The therapy stops working after a certain amount of time. And so another huge challenge is, what do we do next? After we've used that really potent medicine, what are other options that we might be able to do? And this is where thinking about new types of treatment, really understanding the disease biology is important. And lastly, I'll talk just very briefly about variant histologies, or what's historically known as sort of non-clear cell kidney cancer. I always think it's never good to be defined by something that you're not. So this is the bucket of diseases that Dr. Kenney was mentioning, which are individually uncommon, but in aggregate make up about 25% of all renal cell carcinomas. And honestly, we extrapolate a lot. We don't know how to treat individual ones nearly as well as we do clear cell. So we borrow a lot of the same drugs. And so how can we do a better job of treating those specific diseases? So we'll tackle these one at a time. And it's going to be a little bit of a whirlwind, because again, I just want to give a sort of a hint, a flavor of kind of the research going on. So one is, how do we select the right drug for the right patient? How do we develop biomarkers? And the true answer is, for kidney cancer, this has not been nearly as successful. If you think of things like advanced lung cancer, they've had a much more success in picking up DNA changes or mutations that might serve as a marker for responsiveness to drug. This is true of other tumor types as well. Kidney cancer has not been there yet, but my hope is that with a lot of the new tools that are coming out in the laboratory, that might ultimately translate into tools we can use to develop biomarkers and select. And so I have what I think is a little bit of a silly cartoon, but hopefully sort of hammers home why this is a really difficult problem. So we have two patients. One of them has a tumor that responds really well to a therapy. That's in blue. One has a tumor that unfortunately is resistant to therapy. And when we want to study it to try to come up with a biomarker, to try to figure out what's going on. Now, if we look at the tumor itself, we think as a tumor is just one thing. It's not. It's actually a collection of many different types of cells. Within that tumor itself, within that mass that we've seen, there's tumor cells, immune cells, other supportive cells, blood vessels, and there's a lot of heterogeneity differences between them. But what do we typically do when we want to study that, even with things like sequencing? We put that all in a blender, and what comes out on the other side looks like this. It all looks pretty much the same when you blend it together. And then we try to look back and squint and say, why did one drug work for one patient and one drug not work for another patient? When in actuality, we're really having a hard time after we blend everything together, picking out the individual cells in a tumor, the kiwi that might be responsible for a drug working, or the strawberry that might be responsible for a drug not working. And so this is a silly example, but kind of gets at the hint, the idea that we really have to look at the cells individually. And so there's now new tools that enable us to do that. And so we've begun to do that in various domains. And so we've started to do that in not the problem of does drug work or not, but how does a kidney cancer progress? And so the way we did that was to take patients and their tumors who had either early stage disease, as Dr. Kenney mentioned, things that were really confined to the kidney, locally advanced or that just began to spread, or patients who had tumors that were more advanced that really had spread to distant sites or were metastatic. And we actually broke those tumors down into individual cells and sequenced one cell at a time. And that's what this sort of cloud of dots shows. Each of these individual dots is actually one individual cell from a kidney tumor. And we can use that information to try to say what is actually there, what's different between an advanced kidney cancer versus an early cancer as it starts to spread, and how are the communications that Dr. Hurwitz talked about, how do the cells talk to each other? How does that differ between more advanced cancer and earlier stage cancer? That's what we've been working on. Now we're really working on the next step, which is to say, okay, can we use these newer and advanced tools to begin to ask those questions of why certain drugs work or they don't? What's the underlying biology? What's changing in the way cells talk to each other between a tumor that responds really well to immunotherapy and one that unfortunately seems resistant? And that's work that our collaborative group with Dr. Hurwitz and Dr. Kenney and everyone is working on together. A second big open question is, how do we do better? How do we get that 48% of patients who might be having a survival out to 5 years to 70%, to 80%, higher and higher? And I think, again, the key is really understanding the biology of the disease. The steps that need to happen for the immune system to actually work and recognize and eliminate tumor, I think Dr. Hurwitz did a really good job outlining that, but it's a really complicated process. The cancer has to actually release targets that the immune system can recognize. The immune system has to pick it up, has to take it and deliver it to the right cell that's able to recognize it. But that immune cell has to then recognize it, turn on, travel back to the tumor, actually get into the tumor, and actually be able to attack and kill tumor cells. There's a lot of things that have to go right. And we really have to critically understand what are all the things that need to go right in order to effectively design immune therapies. As Dr. Hurwitz mentioned, these cells talk to each other. And he showed one really good example of EGF. I'm showing here probably 20 examples of ways cells in the tumor actually talk to each other. And if you can believe it, this is actually a really simplified diagram. And so what's going on is a lot of complicated crosstalk. And this is what's going to be critical to understand how cells talk to each other. And when a tumor responds really well to therapy, what are those connections or what conversations are happening? And when, unfortunately, therapy doesn't work, what are the different conversations that happen in that case? The other area that we go on, we've talked about a lot about immunomodulation, which is either slamming on the gas pedal, things like high dose IL-2, which really work to turn on the immune system, or taking away some of those checkpoints, immune checkpoint inhibition, which essentially serves to release or cut the brakes and let the immune system go. I think moving forward, we want to try to get a little bit more specific. And the way to potentially do that is to add a steering wheel. If we think of those older therapies like IL-2 is really the gas pedal, and newer therapies like nivolumab and pembrolizumab as releasing the brakes, the question is, can we actually make the therapy more precise and add that steering wheel? And there's lots of different ways to do that. There's been trials here at Yale and elsewhere that have explored cancer vaccines that really try to steer the immune system specifically towards the tumor. But there's really a whole world of ways to really target the tumor directly. The tumor, the thing in the tumor that the immune system recognizes is called an antigen. And so can we design antigen-directed therapies? Things like CAR T cells, which are a lot in the news, vaccines, other approaches. And Dr. Hurwitz has actually a lot of experience working with these cell-based therapies in many different contexts to try to figure out how we can get towards antigen-directed therapies. So next, briefly, we hope that we start off in a patient who has metastatic disease with an anti-PD-1 based therapy. But unfortunately, for many patients, that ultimately stops working. So what can we do after that? And that's where I think really thinking about the biology of the tumor is really important. Dr. Hurwitz really outlined very nicely the types of therapy that we use. And when we think about the systemic therapies that we use for clear cell kidney cancer, there really are certain pillars that Dr. Hurwitz talked about. There's immunotherapy, which I would argue is really a strong backbone now. There's those anti-angiogenics, those pills that help to block new blood vessels from forming, essentially helping to starve the tumor of food. But we really need a new pillar. We need a new target, and that's really been lacking. And the way that we're starting to get there is by understanding the biology of the disease. And this is going to be a slightly more complicated version than Dr. Hurwitz had really nicely pointed out about how cells sense oxygen. And I bring up this slightly more complicated version, and this is a system that was worked out by a number of investigators and actually led to the Nobel Prize in Medicine in 2019, just because it is complicated. And that's why I think the fundamental research, the basic biology is so important, because that's what ultimately leads to these new therapies. So as Dr. Hurwitz had mentioned, under normal oxygen conditions, so if we have oxygen floating around, called normoxia, then VHL is active, and it helps to basically break down, throw into the trash, certain proteins like HIF2. And HIF2 ends up being really a key protein for clear cell kidney cancer. In normal parts of our body, if we don't have enough oxygen, then VHL is not active, it's turned off, as Dr. Hurwitz said. This HIF2 is then, it's not thrown in the trash anymore. It can go and do its job, which is to make new blood vessels or angiogenesis, help the cells grow and survive. In clear cell kidney cancer, we know that this VHL protein is missing. And so this HIF is on all the time. And so even when it's not supposed to, the cells are growing new blood vessels, they're growing themselves, they're surviving, they're becoming clear cell kidney cancer. And so this, now when we know this biology, it's the natural question, can we just have a drug that might help to shut off HIF2? That might help to stop all these things that are happening downstream. And that's where a new drug, belzutifan, which is now approved for specific patients, really for patients with hereditary kidney cancer with VHL syndrome, but is being actively tested more broadly and preliminarily has some encouraging results, really acts to block this HIF2 and stop those downstream signals. And so this is just an example of how the basic biology, really understanding a fundamental process like how our cells sense oxygen, leads to advancements in kidney cancer. The other thing I just want to briefly mention is I talk a lot about new drugs and new technologies, and those are things that I'm excited about. But I think there's also the question, can we just optimize? Can we actually do better with the things that we have? And this is something from when I was at Dana-Farber in the past that always sort of struck me. This is borrowing a lesson from pediatric leukemia. So these are survival curves of children, unfortunately, with pediatric leukemia, and trials done at Dana-Farber in the 1973, 1977, 1980, 1985. So over the course of around 15 years. And we can see this is a dramatic improvement that in the 1973, fewer than half of children with leukemia were surviving. By the mid-80s, nearly 80% were. What I found so remarkable about this is that this was a period where there was actually no new drug discovery. This is all just optimizing the drugs that they had, and they had this dramatic improvement in survival. And so I think it's sometimes not as, it's not as hot a topic to say, let's just optimize what we have, but that sometimes is one of the most effective things. And that's starting to be done in kidney cancer, particularly for patients who had received immunotherapy in the past. People are beginning to ask, can we actually just optimize and tweak things? A standard after someone got immune therapy would be to get a drug like cabozantinib or tivozanib. So asking really simple and fundamental questions, can we actually add another immunotherapy agent to that same drug? So rather than giving cabozantinib alone, can we actually add atezolizumab, another immunotherapy, and get a better response and help patients to live longer? There's multiple trials that are exploring this, but I think goes over with the overall principle, can we optimize the tools that we have? And then very briefly, how do we treat these variant histologies? Essentially, everything I've talked about so far is really for clear cell kidney cancer, but we know that 25%, 1 in 4 renal cell carcinomas are not clear cell. They're these variant histologies. And you just look at them and they're dramatically different. So these are what they look like, both when you just look at the tumor itself, and then next to it is what they look like under the microscope. And I just have a couple examples, a papillary tumor under the microscope. This one's a type 1. This one is what is historically called a type 2. this is a chromophobe, and you don't have to be a pathologist to look at these and say they look dramatically different. They're really not the same disease. And in a table similar to what Dr. Kenney and Dr. Hurwitz had shown, these have a different biology. And so lumping them all together and assuming they all act in the same way and will respond to the exact same treatment is probably just not right. We really have to think about how to do this intelligently. And I think the field is really coming around and beginning to do this. I think for the first time, there was a large trial, it was a large phase 2 trial that really targeted specifically papillary cancer and had a positive result that was really encouraging. And this has paved the way for new trials. This is just one of many that are starting to emerge. This is something called the Smilow trial. This is mostly run actually out of Europe, but it's a trial where it's for patients specifically with papillary cancer, and specifically even that type 1 papillary cancer. So those that have a specific alteration in the DNA, ones that are driven by this protein MET. And those patients, which are very specifically selected, then are getting one of 3 different types of therapies. And so this is just one example of an ongoing trial, but gets the overall point. We have to better understand these tumors, these variant histologies, and that we can't always lump them together. We really have to think about how they're different and unique and treat that individual biology. And so that's briefly what we talked about, some of the big open questions in research, biomarker development, selecting the right drug for the right patients, getting more patients to survive long-term, really hopefully get into that word cure for more and more patients. How can we treat patients for which the initial therapies haven't worked as well? And how can we treat that 1 out of 4 patients that don't have the classic clear cell kidney cancer? And the way we're hoping to do that, and Yale, by working between physicians and lab-based scientists, the way we're really hoping to do that is through really a process of bedside to bench and back again kind of research. And the basic idea here is that we work with patients who are interested in contributing to research. We study their kidney cancer specifically. We go back to the lab and we really try to learn things about their kidney cancer and about kidney cancer more generally. We think about what are the new questions that we have to answer about improving immunotherapies and other types of treatments. We try to use that in a laboratory to figure out how we're going to design better diagnostic tests, better biomarkers, better therapies, and then try to actually bring that back to the patient and translate that into better therapies and better tests for patients. And it's an iterative process, really going back and forth to try to do this in continuous fashion. And so with that, I am thankful to all the patients and families and caregivers who really this research is only possible because of their generosity and the medical providers that really make it happen. And I'm happy if there's time to hopefully answer a few questions.
That was fantastic. I think there's a little bit of time, and then we'll go to Claire. I don't want Claire to. I want to know what she's going to say. So let me start with some of the questions. So one of the questions was, and I'll be interesting to hear your answer because our answers might differ slightly. Is one combination of an INIB and an UMAB better than another for cancer that has spread? So let me just clarify for 1 second for the people there, that we generally start treatments with metastatic cancer with a combination of 2 medications. And often those combinations are one of those pills we talked about, the anti-VHL type, well, the anti-VEGF pathway ones, and one of the immune therapies. So David, are the combinations different from each other or not?
It's a great question. I think if you ask 10 different kidney cancer experts across the country, you're going to get probably 3 or 4 different answers. But I'll say a couple things. So I sort of lump them together into 2 big buckets. Are you going to get 2 immunotherapy drugs together? That's one option. Or are you going to get 1 immunotherapy drug and 1 of those blood vessel blocking drugs, an anti-angiogenic? That's the other bucket. Now, if you're in this bucket of 1 immunotherapy and a blood vessel blocking drug, are there differences between them? There's actually 4 regimens that are approved. The answer is there's probably slight differences between them, but it's probably pretty slight. I think the things that matter probably more than anything else is if you're within that class of drugs, the physician's comfort level in prescribing them. So people who prescribe cabozantinib a lot are going to probably prescribe cabozantinib, and that's probably a better option than people who prescribe axitinib a lot or another drug. And so I think once you're in that class, there might be subtle differences, but they're by and large pretty similar, especially the latest generations. There might be differences in how toxic they are, meaning how many side effects they might cause, and that might help to guide which among those. I think a big question is, how do you choose between those 2 big branches? I think that's a bigger question. How do you choose between 2 immune therapies and an immunotherapy and a TKI. And I think, again, you can go to many experts, and there's no trial comparing them head to head. So no one can tell you that answer for sure. But I'll give you sort of my 2 cents. I think the thing that's been transformative about immune therapy is not only that they lead to tumor shrinkage, but really that for some patients they lead to a long-term survival. Maybe even for that subset of patients, a cure. And while we don't know this for sure, I think there's some reason to think that having those 2 immune therapies together might actually increase the chance of having that longer term survival. And so all other things being equal, I tend to lean towards that. But it's not for everyone. And the question is why? One is those can in certain ways be more toxic. They have more immune related side effects. That's a really important thing. The second is, while they might work better, arguably, that's arguably in the long term, in the short term, they probably don't shrink the tumor quite as well. And so there are patients who unfortunately have disease that might be really rapidly growing, or they might have a lot of symptoms from their disease, where the most important thing is really shrinking it as soon as possible, in which case having 2 immunotherapies might always be the best option. So the overall answer is it tends to be a patient-specific conversation. At least that's my 2 cents, but Mike, I'm curious what your thoughts are.
I'm actually very relieved. I don't have to say anything because that's the exact answer I would have liked to give. I mean, almost, word for word, except said better. So that's fantastic. That makes me very happy. But it's absolutely true that you can talk to 10 different kidney cancer docs and get 10 different similar answers usually. All right. The second question is, when will real information as to biomarkers in patients and their likely response to immune therapies or to targeted therapies happen, and what makes one patient responder versus to something versus unlikely to respond?
Yeah, it's a great question, and one that I wish we had the answer to today. And so the real answer is we don't have great biomarkers right now, and I think we absolutely need to do better and think about every possible domain. Honestly, one of maybe the better biomarkers that's out there is not any fancy sequencing that I talked about, is actually looking under the microscope. We had talked about these sarcomatoid and rhabdoid tumors before. Those are ones which historically, unfortunately, have not responded nearly as well to the pills, those anti-angiogenic medicines, but for some reason seem to have a much, much better response to immunotherapies. The number of actually patients who have a complete response, meaning the tumor seems to just disappear, is actually higher in those patients with sarcomatoid and rhabdoid features. These you only really find by looking under the microscope compared to other patients with kidney cancer. And so sometimes the old traditional tests are still the best ones, but I wish I could say today we have the absolute molecular test that tells us if the drug works or doesn't. We're working on it, but we don't have it yet.
Okay, and 2 more questions. One is, are there metastasis into lung and liver still for chromophobe?
Yeah, absolutely. So this is I think a common question terminology. If someone has a kidney cancer, but then it's moved somewhere else, it's moved to the lungs, is it still kidney cancer? And really it matters less where it is and more where it came from, in terms of how we define the tumor and how those tumors might actually respond to therapy. So if it's a chromophobe that then moved to the lungs and they did a biopsy or surgery and really looked at it under the microscope and it looks the same, but the doctors are really confident it came from the kidney, that would still be the same chromophobe kidney cancer.
Yeah, and it's, although it's rare, chromophobes do metastasize. We see it. To answer that question. And then
I think a really important point about chromophobes is that it's much more common for patients who have metastatic chromophobe kidney cancer to have had metastases at the time of diagnosis. Mm-hmm. It's much less common for someone who's had on imaging, it looks localized, they've had surgery. It's much less common for those patients to develop cancer spread. And, I think for a lot of our patients who have had surgery for a large or higher stage but localized chromophobe kidney cancer, I think it's really important to know that those patients often do quite well and don't necessarily have some of the same level of risks as other more aggressive types of kidney cancers, like a high-grade sarcomatoid clear cell kidney cancer, for instance.
I think it's a really important point.
So the last question, which I don't exactly understand, but I'll say it word for word, and it is, as a stage 4 survivor, now 18 years, thanks to surgery and high-dose interleukin-2, why not review the value of that treatment in light of our better understanding of kidney cancer?
So my sort of sense, and I could be wrong, is that maybe why not go back to high dose IL-2 and surgery, things that might have worked in the past. And I think it's a really good question. Of, we look back, and high dose IL-2 is not something that's commonly used, but there were actually patients who had a really long-term response, probably cure. It was probably on the order of around 5 to 7%, so not frequent. And it's something that can be really toxic. So it's typically administered in a really monitored setting because people can get very sick. And so the question is, why don't we do it more commonly? I think the short answer is, one, we have tools that we think are maybe slightly better, these immune checkpoint drugs. And two, what's actually being studied are similar medicines to high dose IL-2, but that have been modified to try to make them a little bit less toxic and maybe a little more efficacious. And so those drugs are actually, these modified IL-2s are actually in clinical trials now.
Yeah, so I would add to that a little bit, which is that it is happening, is the point. There are a bunch of drugs out there that are thought to be better IL-2s, but use the IL-2 biology, that are being studied currently. And they're going to be doing it in combination with the other types of therapies. So it's all happening, and hopefully it'll be great. All right, let's move on to Claire Healy, one of our geneticists.
Pat, do you have one comment? Sorry.
What was that?
Oh, no, sorry. There was just one more question in the Q&A, and it just asked about how severe are the side effects of the oral medications for kidney cancer compared to what we think of as traditional chemotherapy, nausea, hair loss, things like that.
So in brief, they're quite different. So and it depends. So I think they're not as bad acutely, I would say, although other people could disagree with me. But the problem is that you take them for a long time, you take them every day, and they can be incredibly wearing. And some people just do have very bad side effects, but the side effect profile is quite different. I would say the number one thing is GI issues, a lot of diarrhea for some people. There can be a lot of rash for some people. That can be quite difficult. Appetite can go down. There can be nausea. A lot of fatigue can happen. And so it's very hard to compare because it's a chronic thing usually versus chemo, which is sort of happens and then gets better, happens and gets better. There's probably a better answer out there. I don't know, David, you have a better way to put it?
No, I think that's sort of short but more severe versus longer but kind of wearing is probably a really good thing. And everyone sort of is different in terms of the side effects they experience. I think probably on average people think of these as being, they feel less bad than the conventional cytotoxic chemotherapy that would make people lose their hair and make people nauseous. But you can imagine it's one thing to have that dose of chemotherapy and feel really sick for a couple of weeks versus something that maybe makes you feel a little bit tired but kind of wears on day after day after day, that after months or years of it, it might sort of build up. I think that's the difference. And so you're absolutely, I think it's hard to compare.
Let's move on. So someone said that hand-foot syndrome is gnarly. It absolutely is. So there is a question, but you're going to hopefully answer it because it's what are the genetic predispositions for RCC and other things. So
I'll get started. So my name is Claire Healy. I'm one of the genetic counselors in the Smilow Cancer Genetics and Prevention Program. Can everyone see my slides?
Yes.
All right, perfect. So I'm going to do just a brief overview of hereditary kidney tumor and cancer syndromes. It would be impossible to do a deep dive in a short period of time, but I'll do my best to give kind of a brief overview. So we'll start just by kind of pointing out that while we're going to talk about hereditary kidney cancer syndromes, hereditary kidney cancer and tumor syndromes are actually fairly rare, and most cancer is not hereditary or genetic. So most cancer, 70% of cancer, is actually sporadic. And that just means that it's caused by things like the normal aging process over time, lifestyle factors, environmental exposures. And in most cases, when we look at a patient's personal history, family history, when the cancer is sporadic, we'll expect to see those cancers occurring kind of at later ages, general population ages. When we look at the family history, we'll expect to see a random mix of cancer types in the family. Another 20% of cancer is explained by a familial predisposition. So these are families where we might see multiple people in the family who are developing the same type of cancer. And so we might see a higher than average risk for a certain type of cancer. But we would still expect to see most of those cancers developing at average population ages. In most cases, we wouldn't see rare or unusual types of cancers. And these are really clusters of cancers that are likely explained by some shared genetic risk factors, but alongside a shared combination of lifestyle and environmental exposures as well. And then really only 5 to 10% of cancer is explained by a hereditary cancer syndrome. And so these are situations where there is a greater lifetime risk of cancer. The cancers are typically diagnosed at younger than expected ages. There's a greater chance of developing a second cancer, and we usually see more rare types of cancers as well. And in these families, we may see the same type of cancer or related types of cancers clustering together. So in terms of what we look for, what you should look for, what your doctors are looking for, and what your genetic counselors are looking for to kind of give clues as to whether there's a hereditary predisposition for cancer in the family, are things like cancers that are diagnosed at earlier than expected ages. So for kidney cancer, we usually say that's under the age of 47, 46, 47. I know that sounds like sort of a very arbitrary and specific number, but there is research out there that says really anything under 46, 47 is where the risk for a hereditary syndrome really starts to increase. We would also expect to see multiple family members on the same side of the family with the same type of cancer or related type of cancer or tumors. So this might be a mother and a child who have both had the same type of kidney cancer, or two siblings with the same type of kidney cancer. And then we can see rare cancers or rare tumors, such as angiomyolipomas or chromophobe tumors that have already been mentioned tonight. And we might also see a person who's developing multiple cancers or tumors. Sometimes this is multiple tumors in the kidney, but other times it's multiple different types of cancers or tumors. And rare benign tumors. So in a lot of our hereditary kidney cancer syndromes, these are going to be rare benign tumors that are developing in the kidney, but also rare benign tumors that are developing on the skin. Sometimes those are lesions on the skin that might be very subtle and that you might not even notice yourself, but that a dermatologist might be able to see. Other times those might be things on your skin that are, sort of just skin colored, but maybe you notice that they're really sensitive to the cold, or when you touch them, they're a little bit painful. Sometimes these rare tumors are things that develop in the brain or in the lungs. And so they're not things that you would encounter kind of in the general population very often. And when we talk about hereditary syndromes, really what we're talking about and what's already been mentioned tonight are these genes that normally are kind of helping to prevent cancer. So they're keeping the cells in our body kind of growing and dividing in a really regimented way. And so, like what's been mentioned previously, most of the time people are born with two healthy working copies of those genes. And when that's the case, the way they develop a tumor or a cancer is that both copies have to become damaged, or what we call mutated, over time to allow the cell to start growing, dividing out of control, forming that tumor and eventually the cancer. In individuals who have an inherited cancer predisposition syndrome, what happens is they actually start their life one step into that process. So they are born with one healthy working copy of these genes, and then the other copy in every cell of their body contains a mutation. And so they're sort of down one line of defense when we think about cancer, because now it's going to take just one random event to occur before the tumor or the cancer can develop. And that's why we would expect to see younger ages at the time of diagnosis, a higher cancer risk overall. and why we can see multiple tumors in multiple different areas of the body. So this is a very busy slide, and I apologize that it's so cluttered. But when we think about our hereditary kidney tumor or cancer syndromes, these are the most common ones. There are some other ones, but these are the ones we think about the most. And you can see that when your doctors are meeting with you, or if you meet with a genetic counselor, really what we're thinking about first are, what type of kidney tumor or cancer do you have? That helps us kind of narrow down what syndrome might we be thinking about. So we've already talked about VHL tonight, which is associated with the clear cell type of kidney cancer. But we also have hereditary syndromes that are associated with other types of kidney cancers, like papillary kidney cancer, chromophobe tumors, the angiomyolipomas that were mentioned earlier tonight. And then, so that helps us kind of narrow down, okay, what syndrome are we thinking about in that individual or the family? And then we think about, are there any of those other features that we would expect to see in that individual or the family, like some of those non-cancerous or the benign tumors in other areas of the body. So when you meet with a genetic counselor, we spend a lot of time talking about your medical history and your family history. We ask you what feels probably like a laundry list of questions about different aspects of your medical care and your family members' medical history. But really the reason we're asking those detailed questions is because we're trying to narrow down as much as possible what hereditary syndrome might we be thinking of. And then just in terms of basics of genetic testing, if you are thinking about genetic testing and you do meet with a genetic counselor will kind of go over different test options with you, insurance coverage, answer all of those questions. But just to give you a little bit of background, genetic testing can be completed from blood or from saliva. It is covered by most insurance companies. Especially if you have a personal or a family history that's suggestive of a hereditary cancer syndrome. So again, if you're young when you're diagnosed, if you have a family history of a first or second degree relative who was young when they were diagnosed with cancer, if you have some of those benign rare tumors, all of those things are going to suggest that there's a hereditary risk. And in most cases, you will have coverage for genetic testing. Luckily, the price of genetic testing has come down. So if in the unlikely event you do not have coverage for genetic testing, most of the time we can complete that genetic testing for an out-of-pocket cost of around $250. And a lot of the genetic testing laboratories that we use do offer patient financial assistance as well. And there are federal laws that prohibit genetic discrimination by health insurance companies and employers, with some rare exceptions, particularly for our active duty service members. And that was my last slide.
I was on mute. That's fantastic. Excellent. That was great. So, and there are questions that are absolutely up your alley. So the first question is, what are the genetic predispositions for RCC? And I know you know the answers to the others too, and skin or bladder cancer.
So there's not necessarily one syndrome that connects all three of those together, but there are a number of hereditary kidney cancer syndromes. Some of those increase the risk for melanoma as well. So if we're talking about a skin cancer that's melanoma, that could be a concern. There is a hereditary cancer syndrome that does increase the risk for bladder cancer and collecting duct tumors of the kidney. So if you have a family history, a personal history of all of those cancers, good idea to ask for a referral to a genetic counselor.
Great. And second question was, my dad had a tumor. No, there's another one. Sorry. My brother and I were both diagnosed with clear cell kidney cancer. We both completed genetic testing with no concerns. How concerned should we be for our children inheriting clear cell kidney cancer?
So one thing that I would say is, just like most medicine, genetic testing gets better with time. So if your genetic testing was performed a while ago, we likely have newer genetic testing technology that can evaluate the same genes, but pick up mutations that may have been missed previously. So if your genetic testing was completed a while ago, good idea to contact whoever performed that genetic testing or ask your doctor for a referral to a genetic counselor to see if updated testing would be appropriate. In families where there are multiple relatives with a tumor type where we do not identify a genetic predisposition, it doesn't mean that one doesn't exist. We don't know of all genes that are associated with these hereditary cancer syndromes. And also there's still that risk of a familial predisposition. So not one single genetic factor, but a combination of factors. So in that case, with two relatives closely related to one another with the same tumor type, I would still estimate that their risk for other family members to develop that same tumor type would be higher than in the general population.
That's a great answer. Let me add one or two things, and other people can correct me if I'm wrong. You know, sometimes it helps to know a little bit more about the situation. So, you know, are the tumors big? Are they small? How old were you when you got them? If you're both 80 years old, still, it's not super common that you'll both have that, but it may not be so uncommon. If you're both 55 years old, that's different. So, but I think that point you made is so important, that just because we don't have a name for it doesn't mean there isn't a genetic thing out there that we don't know of yet. Is that, yeah.
And then Dr. Kenney is reminding me that I said a while ago, but didn't really define what that was. So anything more than 5 years ago, we always recommend our patients contact us every 5 years to see if there's any new genetic testing technology that would be worthwhile updating their genetic test with.
And so this person actually answered and said they're in their 50s. And my answer to that is go see Claire, because you know what you're going to do, and maybe you would say this already, is that you do a whole history about what's going on in the family and all those things. You can get a lot more information by that, right?
Yeah, absolutely. And even if there's not updated genetic testing, we can talk about risks to relatives, what those risks may be, and can also help make connections for unaffected people in the family with high-risk providers who may be able to offer screening.
Okay. And the last
another really important thing to think about too is shared exposures. And so sometimes if a patient has a kidney cancer and a bladder cancer, it may not be a genetic predisposition to that, but perhaps they had an exposure that may have increased the risk of both. And so I do think we see that a lot. I think we also see it's fairly common to diagnose a second cancer in a patient who's had a cancer, and because we're doing imaging, and we might find something that wasn't causing any symptoms. You know, we're doing a chest scan because someone has a bladder cancer. It shows a thyroid nodule, which leads to an ultrasound, which leads to a biopsy, which leads to a diagnosis of papillary thyroid cancer, and that's a very, very common course of events. And so sometimes these clusters of a couple cancers may just be by chance, or could be from an exposure or genetics. But this is
hugely important point. Yeah, that we're sort of more biased once we hear it from one thing. Let me go to the last question that I see. Actually, two more, but one is, my dad had a tumor in his bladder and had a urostomy. Can that be hereditary? But instead of the cancer being in my bladder, it was in my left kidney. So in other words, yeah, you got that?
Yeah, great question. So is it possible? Yes, absolutely. It's possible that there could be a genetic syndrome that links those two cancers together, but it's also possible that they're completely unrelated to each other and both just occurred by chance. So again, I'd have to have more information about ages at the time of diagnosis and other family history, which is why a genetics visit is probably the best step if you have those questions.
Yeah, and as Dr. Kenney pointed out, there are cancers that are in the kidney that are really more like bladder cancers, but they're really different from what we consider kidney cancers. If you have what we consider a kidney cancer and your father had a bladder cancer, probably not related. I think it's a fair statement. But and then the last thing was, can we go through your place to do a test?
Yes, absolutely. So the Smilow Cancer Genetics and Prevention Program, our main hub is in New Haven. but we also see patients throughout the state of Connecticut at various other hospitals. So we're in Trumbull, we see patients in Waterford, we're in Greenwich, and we also have an outreach arm up at St. Francis Hospital in Hartford. So you can, if you need a contact information, you can actually email Smilow Cancer Genetics at ynhh.org. Let us know where you live and we can help find the best clinic for you, and we can tell you how to get your doctor to refer you over.
It was actually put into the chat, that number. Some people aren't great with the web. Is there a phone number?
Yep, and it looks like Renee actually put the website there too, but the phone number is 203-200-4DNA.
Perfect. That's very very fitting. All right. I think we're done. And anyone have anything else to add? Well, this has been exceptionally informative to me, so I hope it's been informative to everybody else here. It's great. And by everyone, if you have questions, you can always, I'm sure there are ways to reach out to any of us. And have a great evening.
Thank you,
Thank
everybody.
you. I learned a lot too, so thank you.
This was wonderful.
Okay.